Okay, so we're going to have a panel, and our panelists I'll introduce you to in a second. But I think the cases follow very nicely after the discussions that we've had, and that I'm sure Mona will soon give you. So my name is Susan Mandel. I am your moderator, and I'm an endocrinologist at the University of Pennsylvania. And our final panelists, because two people unfortunately were not able to stay, are Dr. Beck, coming up right here, who is a radiologist from Korea, Naifa Busadi, who is coming up over here, an endocrinologist from the United States, Megan Haymart from the United States, an endocrinologist, Fausto Palazzo, a surgeon from the UK, Frederick Sabag just dropped off, so we have one surgeon, so all of the pressure is on you. And Peter Kopp, another endocrinologist, but Peter might be able to play surgeon. Okay? So what I'll do is start with one case and then let me know how you want this to go. And I've been an endocrinologist at my institution for 21 years now, which means I have patients whose histories go back a long time. And I think one of the themes that you heard this morning in a number of the talks, and you heard yesterday from Matt Ringel, is that things stay dormant for a long time and then they grow. So when you've been seeing a cohort of patients for a long time, you actually watch this happen in your practice. And I tried to pull some of those cases that exemplify some of the themes that you've heard about. So we're going to go back almost 20 years to February of 2000, when this 43-year-old man had a thyroidectomy, and we don't have all the details. This was 20 years ago. It was a 6.3 centimeter papillary cancer. This was at a different institution, and all I know is that he got 124 millicuries of I-131, and there was uptake bilaterally in the neck. I cannot tell you where that was, but those of you who are in practice know that these are the types of patients we can see. He then transferred his care to us about 8 months later. And what we did was we did some imaging, and we found this mass in his left level 6-7 extending into the upper mediastinum. And this was resected by one of our surgeons and read as a 3 centimeter PTC follicular variant with vascular invasion. He did have a chest CT at that time, and it showed, and remember this man is 43 years old, a very small number of very small lung nodules, the type that with Fleischner criteria, if you didn't have a history of a malignancy, you would actually not even recommend a follow-up CT. But you can probably guess where this is going. Now, this was back in 2000. So I will just like to ask our panelists, because we did talk a little bit about radioiodine, and remembering that he got radioiodine in April, and you can answer it as if it were today, but here we know that his chest CT really has insignificant nodules, and this is his withdrawal TSH and thyroglobulin, and I can tell you that his diagnostic scan is negative. In today's world, would we treat him with radioiodine? Peter, you're looking at me.
Well, I was just going to ask you whether you treat him. So, a lot of people would treat this patient with the notion that the lesions are so small, so we may not see them, and so this may have a positive impact. Others would maybe have observation, but I think the majority of people would still treat this patient.
I think probably in 2000 it was probably more clear-cut that most people would treat someone like this. Other members on the panel want to talk about treatment maybe today in 2019 versus I think in 2000 it was probably more clear-cut that people were giving a lot more radioiodine, but what you might do today?
So just to comment, so this gentleman he's young, right, 43 years old. And has small lung nodules with an elevated TG. So yes, his diagnostic whole body scan is negative, so the likelihood of him taking up iodine is low, but there is still some potential, right, because he's young and he does have lung nodules, that his post-treatment scan would light up. So more than likely he's resistant, but I think it would be fine to still treat.
Okay. So he did have a 1.7% uptake in his neck, but they didn't see anything there. These were those older scans. He did get treated with 100 millicuries, and his post-therapy scan just showed focus in the left bed. And he went on his way. So again, summarizing a decade, So back in the day, we used to do withdrawal scans. This is right when people started to switch over to thyrogen. And you can see a year later, he got withdrawn, and his withdrawal thyroglobulin was only 2 with a negative whole body scan. And just to summarize, if you look over this 10-year period, you can see that he had a very low detectable thyroglobulin with a low TSH. You can see that on his chest CTs in 2005 and 2008, he wasn't the best at follow-up. He lives about 2.5 hours away. His lung nodules were pretty stable. And you can see that in 2008, I even threw in a thyrogen-stimulated thyroglobulin just to see what would happen. And then 2011 came, and I'm one of these people who repeats things. So you can see in 2011, his TSH was pretty similar. This is all in the same assay for the thyroglobulin, but his thyroglobulin was a little bit higher. So you can see I repeated it in April, and it still was. It was a little bit higher. And I went ahead and just showed you this because I'd like to get to some of the points here in the case. But I went ahead and we did do the neck ultrasound that was negative, and his chest CT now showed that his lung nodules are actually larger. So is this what we've been hearing about this morning? Or is this something else?
Well, what this documents that there is residual disease, and with small progression, I think you're doing the right thing with close monitoring. You try to treat with radioiodine, obviously without any significant response. I think what is reassuring so far is that the progression has been slow, and the question is, when will this perhaps accelerate?
Are you sure these are thyroid cancer?
Well, we don't have any histological proof, so I think that is always a challenge, but we assume that may be thyroid cancer.
So one of the things that I tell my patients in addition is something that bugs me is the thyroglobulin 0.6. So before, when you showed the first slide, before you treated with that second 100 millicuries, the thyroglobulin was what, 20-something?
Yeah,
29 or something. So I was okay giving a treatment there and saying, hey, these lung nodules are probably, they potentially are thyroid cancer, they're either resistant or not. But now your TG's 0.6 and your chest CT is growing, so it still could be, but if it is, it's a less well-differentiated thyroid cancer.
So let me show you his chest CT. So he now has these 6 to 10 bilateral pulmonary nodules, and you can see one there in the right lower lobe, just as one of them, and these are the sizes. So they've grown since 2008. So what next? Are we going to keep following him? Are we sure? Ideas about what to do? Comments, Megan?
So does he have any symptoms at all?
Nope, he feels fine.
So, you know, his thyroglobulins in the indeterminate range. We're suspicious that these lesions are thyroid cancer, but they can be very slow growing in patients, and it can be many years before it sort of blossoms. So we would probably continue to follow him closely.
Does it bother you that his thyroglobulin stimulated so high and now it's so low? And even if I go back and I look at his stimulated thyroglobulin, you can see how low it was, but yet his thyroglobulin was quite high at the time of that initial withdrawal, and that growing lung nodules, when his pathology was PTC